So, where are we, Mo?
We're in Jack's Coffee House in Babylon Village.
All right. This is what we ordered today. Oh, wow. There's all this steam stuff.
We
I don't know
ordered
if you can really see that, but
a cappuccino with one shot of espresso in each cappuccino, and I got one that's flavored with vanilla.
nice. Yeah, so there's so much frothy stuff here, and I can barely hear myself talk, but yeah. Hopefully everything
Can we
goes well.
turn the volume of our mics up?
No, it'll naturally reject sounds around it and more get sounds from our microphone, whatever's closer. So
So today's Monday, February 28th, one day before March 1st. The year is 2022. It is a really cold Monday, like a super cold Monday. I'm actually wearing like a really thick sweater, and I'm still freezing.
yeah, same here. Like I guess we're right next to the door, but this is definitely one of the best tables to do that. It's pretty it's a longer table, so it's nice. Now I think you can see it. There you go. I don't want to drop it on my book bag.
The coffee's really good.
Yeah.
We actually been to this place before. I think it's dog themed, so I think sometimes they can give like puppuccinos. Have you ever heard of puppuccinos?
No, I haven't. I feel like there's a lot of dogs in this area though. We've seen like six dogs pass it.
We've seen like 4 dog walkers. So this is a very common place for people to walk their dogs.
Yeah. Russia just invaded Ukraine about 3 days ago.
That's the world events going on.
Right. And Kiev, right now they're at Kiev, but they're negotiating, but it seems like arbitrary negotiations.
Yeah. Which makes everything intense. There's a little dachshund walking in.
Oh.
So cute.
It's now not required to wear a mask in public buildings. It's like the first month.
They say Long Island's finally in a green zone with COVID infections, which is which is a nice highlight in today's world. So what have you been up to, Michael?
Yeah, lately just been coding, doing something called HubSpot, which is
What kind of coder are you?
So I do full stack right now, and but mainly I just do back end stuff. And with the back end, we do tons of things like integrations with other company stuff, and that's called an API, right? So an API is just the way that your software integrates with another person's software, really, yeah, essentially.
Now, is software like some sort of computer program that runs a function?
Exactly. So, right, it's essentially, instead of recreating an entire world, and instead of recreating stuff and then having to test it and manage it, you work with someone else and you just pay them the stuff, right? And that's exactly what an API does.
So are you like someone, like another company like Microsoft, like they would go and contract you to make some sort of API function?
That's called SaaS. So SaaS is software as it's like software as a product. I don't know what it stands for. And basically what happens is people hire these groups to pay for to just do software work for them. Yeah, no, we're more of a point of sales company. And a point of sales company, essentially, it's that. It's at the point of sale, right? We manage that software, right?
Interesting. So you used to. I don't really know much about coding, but you told me that there is a front end and a back end.
Right.
What does that mean?
So with the front end is basically like user interface, right? Whatever the person interacts with. Whenever you open up anything, it's a user interface. Like, for instance, right, this is literally a user interface. Once I touch the screen, whatever you see is the user interface. The interface with the user, right? Now the back end is everything else. It's basically as vague as that, right? It's like everything that happens behind the scenes.
Would you describe it like as if it's like a tip of a glacier, and then like the front end is like that small tip, and then underneath the water, the back end is that giant, deep,
exactly,
long, like glacier underwater?
That's a good way of putting it. Yeah, it's kind of like what supports whatever you see.
So basically, the front end is what makes it pretty, what makes things ergonomic and smooth. But like, if you have a good front end but a bad back end, that's when you get like you press something and it doesn't do the thing that it does.
Could also be the front end and the button is just not working. They're actually playing Frank Sinatra.
I know. I was thinking, like Frank Sinatra.
Yeah.
This feels like a true coffee house.
It's like some guy with the violin just walked in. And like, imagine if that just happens. This is nice. These are always
This is a nice coffee.
Yeah.
The cappuccino is really smooth.
I know, this is really like, it's like sweet, but it's not sweet with coffee, not sweet with sugar.
Yeah, it's really good.
Any new events happen at your work?
Nothing much. Work was pretty quiet for me. I have a patient that stayed, that I've been with for. This patient's going to be here for a while, so I had him again, and like it was pretty okay. Yeah, and the other patient I had didn't really need ICU, but she was a rapid response on the med-surg floor. So they wanted to keep her overnight because she had something called flash pulmonary edema.
Okay.
Flash meaning quick, pulmonary meaning lungs, and edema meaning fluid buildup. So she had fluid buildup of the lungs.
Gotcha.
And that kind of etiology is really common in patients who have congestive heart failure, where the pump of their heart isn't really working the best it is. And congestive heart failure, you can kind of diagnose. One of the diagnostic tools for CHF, we like to nickname them CHFers, is ejection fraction. So if your ejection fraction is like less than 35%, you might have, something.
I see. You said that, how long is like the most longest stay in ICU?
So when people get like really messed up, patients can stay in the ICU for, the longest one I've noted is one for 6 months. And that's related to, there is a lot of complications related to patients who stay for that long. They usually come in with one thing, and then it starts to trickle into another thing, and then it goes into another thing. So a lot of the times when patients go into the hospital, it's related to some sort of septic shock cascade.
Okay.
And then their heart gets, they have a heart malfunction, or they weren't healthy to begin with their heart, or they have hypertension, they have underlying comorbidities that they never got checked out, and now that is interfering with whatever disease process they're facing.
Okay.
So that's what kind of happens with patients who stay there for a while. So, or something happens, like a lot of the times there's patients who stay there. I've noted, like even from my prior job, this job in the ICU, is related to like belly stuff.
Okay.
Like our gut is so important with our quality of life and living, especially our pancreas, our spleen. Like if those two get affected, you can really see someone go down very quickly. Like splenic injuries, severe pancreatitis or necrotizing fasciitis in the pancreas, or necrotizing fasciitis in like several parts of the gut.
What do you think? I never heard someone be like, my spleen. You know, it always feels like a joke when someone says that.
Well, trauma. So like when people get into, and these are like the kind of patients that last in the hospital for a very long time, and they're like revolving in a door, like a revolving door. They're in the ICU. They go to step down. They go to the floor. They're rapid. They go back to ICU because they're that sick. Now, I may be misremembering this, but like the spleen has a lot of vessels that innervate it with blood. So in trauma cases where that spleen gets injured, we grade it. So it's like a level, or liver. Oh, not a spleen. Maybe it's a liver. I don't quite remember. I know both of them, they can get injured severely, and that can be a really poor prognosis for the patient. But I'm misremembering it. So like they can get a level 1 liver lac, a level 2 liver lac, a level 3 liver lac, a level 4 liver lac.
Okay, gotcha. And by lac you mean laceration?
Yeah, and that really happens with like car accidents, MBAs.
I see.
And it's very devastating when it's like a very severe liver laceration.
I see.
Because that area, I believe, is innervated and supplied by the mesenteric arteries. So they can really bleed out. So those people can be mass transfused with, they can be called an MTP, or a mass transfused protocol.
Okay.
But those kind of people also have, like what I drawing back from my original point, is those stay in the hospital for a long time because they require blood transfusions. Sometimes, they can get dead bowel disease where they require a TPN and they need, depending on how severe the damage to their bowels, they might not have, they might have to get a colostomy or something, or they might have to stay on TPN for years, which is, it's the quality of life. It's very difficult for them. And then they get depressed, or, even though they're having issues with their stomach, now they're starting to have issues with their heart, because it's all stressful to the heart. So it's a lot of comorbidities attacking people at once. And in general, like it's people who have underlying comorbidities that come into the hospital that remain undiagnosed because they've lived with their body, so they don't really notice if there's an issue, or they're not aware,
I see.
So that's the longest. I know there was another patient that was like in the hospital for like years. So not years, months. I'm being facetious, but also related to stomach issues.
Okay.
So, but I don't really know much about trauma. I'm not specialized in trauma, so this is all like stuff like how people explain it to me, and like our trauma surgeons and our trauma PAs, they are like encyclopedias. They can like whip things out from like well-sourced information and just teach you, and it's such a great learning experience too.
That's cool. I feel like with the trauma, you probably have a lot more harder time, like what is really going on, what's really wrong,
Well, I don't know. That's hard to say because I really haven't been in trauma. It could be because like then you have like patients who come in for trauma and they're just like a really bad gunshot wound.
Okay.
You know, like that they like nicked an aortic artery or something.
I see.
So you can
Trauma is such a broad term.
Yeah.
It could be a laceration to your finger, or
It could be
someone shot your liver.
Your finger got cut off.
And I was like,
But I'm actually more neuro. I'm getting my neurocritical care certification for my unit that opens tomorrow.
Oh yeah, wow. Yeah, right. You're saying that you're at a massive unit, but is the reason why is because they're just taking time to open up your floor for they're revamping it or whatever.
Yeah.
Or opening it for the first time.
We're opening it for the first time. Yeah. So I'm a neurocritical neuroscience intensive care registered nurse. So what does that mean? It means I'm a registered nurse, and I take care of patients who suffer neurological emergencies such as strokes, different kind of strokes, and anything that really deals with specialized issues to the brain. It could be patients who need a tumor resection, or they have a massive brain bleed, or they have a stroke and they received medications for that, or they received surgical intervention related to their stroke. Yeah.
I see.
So everyone hears about strokes because that's the first thing you learn about. There's this acronym called FAST, right? It's like forgot the other ones. Slurred speech, face asymmetry, slurred speech, time to call 911, right? So why does that happen? So there's two different types of stroke. The most common one is ischemic stroke, or thrombolytic strokes, or thrombotic strokes. That's related to a blood clot that travels through the vessel and gets lodged in one of the main vessels or main arteries of the brain. So you have different kind of strokes. You have lacunar strokes, which are blood clots that go into smaller vessels of the brain, and they call that like they call the prognosis and the care and the long-term disabilities of lacunar strokes are more positive than the ones that cause major like ischemia in the main arteries. So like the most common kind of strokes that have blood clots go into the middle cerebral artery of the brain.
Okay, right.
So
but the reason is because everything goes there?
And it's large.
Okay.
So with the stroke, they say it's called time is brain. So the brain is very sensitive. It needs a lot of blood. It needs a lot of sugar just to function. So when you start having stroke-like symptoms, the tissue of the brain is being affected, and that tissue is called penumbra. So it could be damaged tissue. So as soon as your loved one has like stroke-like symptoms, you want to call 911.
What does penumbra do? Is that soft cushiony stuff?
No. Penumbra means the area of the tissue that is affected by the stroke.
Oh, okay.
So it's the ischemic area. It's the main core of ischemia in the tissue of the brain.
Okay.
And then there's like a surrounding area where there's still blood flow to it, but it's not considered like a dead zone. So that's called penumbra.
Okay, cool.
So when you go to the emergency room, your loved ones will be like, the the emergency care doctor will be asking, like, when was the last time you noticed they weren't having these symptoms of slurred speech? They couldn't move their arm up. That's called the last known well, and that's how we dictate our care. So the current guidelines by the national powers that be is that if you notice that they were having stroke-like symptoms within the past 3 hours, 3.5 hours, they're what we call a candidate for TPA. TPA is what we call a clot buster. So if their CAT scan shows that there is a big clot in their brain, we can administer a clot buster. However, there's a conundrum. There's a few caveats with TPA. And it's like if they had major bleeds in the past, or if they had major surgery, like a CABG within the past 3 months, they might not be a candidate, and they might have to go for a different procedure called a thrombectomy. Thrombo meaning clot, ectomy meaning cutting off, removal of. So
they're removing the clot from the area if the TPA doesn't work?
Manually.
Okay.
And usually what happens, from my experience, I haven't been, and I'm not by any means super experienced in my profession. However, from what I've noticed is that they give TPA and they also do a thrombectomy. So take what you will from it.
Now, this thrombectomy, that's literally the removal of a clot. They go through a bigger artery?
Yes, they do. And that's a good point, because that's very important in nursing care for patients who get thrombectomies. So they'll go into the neuro intervention suite, and they'll come up to us. They might come up to us intubated if they have a really bad Glasgow coma scale.
Okay, wow.
Or they might not be. They might just be talking to you and they're drowsy. But when they have that procedure, they're usually intubated. They can be extubated. So during that procedure of a thrombectomy, they actually go through the femoral artery. So the best place to go through the femoral artery, they puncture through the groin site, the right groin site or the left groin site, and they'll snake catheter all the way up into the brain and pull it out.
It's nuts.
It's neuroscience and neurointervention care is absolutely phenomenal.
Yeah.
But and the neurosurgeons, they're like, God bless their souls. Because they're on call too. If they're specialized and they're the only person that can do this procedure, they're coming in the middle of the night. Because not everyone has a stroke Monday at 8 a.m. when everyone wants to go to work.
They have to always just be there. That's what I'm saying.
Yeah. So they'll have the intervention, and there is reperfusion scoring when they have that. So I think what they do is that they put a dye into it after they pull out the clot.
Okay, that makes sense. Was this effective? Right.
Yeah. So it's called, there's a grading scale, like a tissue reperfusion scale, and it's called when we communicate with one another, I'll be like, oh, what's the Tiki score when I talk to the upcoming nurse, and they'll be like, Tiki score is perfusion 0 or Tiki 2B, and that's related to how much of the brain got reperfused after you pulled that clot out.
Okay.
Because again, time is brain, right? So if you were able to go and get that procedure within that 3.5 time limit, you might save tons of brain, or you might not have. It's hard to.
I think so, yeah, right.
It's really being fast and recognizing those
within
symptoms.
3 to 5 minutes, you lose most of the stuff that's not oxygenated.
It's so bad. And the language with stroke is so different. You think strokes are so simple. You just go to get a procedure and you're fixed. But there's so much niche language and understanding, and neuro exams are so in a way subjective because each patient is different. Each person's different. So like their brain, how their brain function is affected is like so different too. So they go through the femoral artery. We receive them. Sometimes we receive them intubated, paralyzed with no reversible, and we're taking care of them. And we'll see what kind of, what were the symptoms. We'll ask the nurse what were their symptoms before the procedure, and then we'll compare it to when they start waking up. And what kind of assessment we use is called the NIH. So the NIH is the bread and butter of doing a stroke assessment.
I see.
And it's like a very arduous kind of assessment, but we're trying to see where the deficits are, if they still have deficits. So we shine lights in their eyes to see their pupillary response, if their pupils constrict. We see if there's a facial droop. When they smile, does one aspect of their face just remain flat when they do smile? Or can they lift up both their arms? And if they do, is there something called a drift? Like when they close their eyes? Do they have ataxia, which is like kind of, like we call it like the drunk person's gait. So if they're like trembling when they're trying to do something and they didn't receive anything to make them like that, that's like related to like a deficit from being a deficit of strokes. So I lost my train of thought. So the NIH. And then there's also this thing called extinction. Like, can they feel? Do they have sensation of that extremity? So it's all really important aspects that we have to take note of. And like we hope for that their symptoms get better, not worse. If it gets worse, then we have to go for a CAT scan and see what's going on with their brain. So let's say you have a patient who received TPA, the clot buster, but they didn't get a thrombectomy. So they come in with their NIH score is 0, which is a good score. That means that they have no deficits, and they're as red as rain. We caught it in time. It's great. But let's say and we do the NIH scoring for 24 hours post-procedure, because that's the most critical time for them to have any type of issue after the procedure. So let's just say hour 12, they start slurring their speech again and they can't lift up their left arm, and they receive TPA, we're going to worry about what we call a hemorrhagic conversion. And a hemorrhagic conversion, basically, hemorrhagic meaning blood, bleeding out, and conversion, what it says on the tin. So that means that their thrombotic stroke with the TPA converted to a bleeding type of stroke. So they're bleeding into their brain. And that's like also a major issue too. Like if it's a big bleed, what we're gonna do is that we're gonna reverse the bleeding. So we might give like we might give TXA, we might give fresh frozen plasma, we might give platelets to stop the bleeding, and then they're on what we call a hemicranie watch. So a hemicranie means hemicraniectomy, meaning half, hemi meaning half, craniectomy, cranie meaning head, and ectomy meaning removal. So they're removing half of the skull of the head to help any type of deficits. So, and let me explain what I mean. Why would a person be on a hemicranie watch? Why would they cut off half their skull if they're bleeding into the brain? So there's this theory and hypothesis called the Monroe-Kelly doctrine. And what that means is that like the skull is a fixed body of space. So there's like percentages of the head. There's like percentages of space that can be within the head, and if it starts increasing without another aspect of it decreasing, that means that something is being compressed and being damaged. So what neurosurgeons will do to help prevent swelling from the blood starts ballooning into a space of the brain and starts compressing on very important structures in the brain, one of them being the brainstem. So if something gets compressed onto the brainstem, that could be what we call a herniation. So they don't want herniation. Herniation is bad. That's as bad as a heart attack. That's a brain heart attack. So they'll do a hemicraniectomy. So let's just say the patient's getting worse. They'll actually cut off that part of the head so the brain cell swells outwards and not inwards on the brainstem. If that makes sense.
So what happens is brain has a limited size to grow, to swell up inside your head. If there's not a lot of room, it kind of suffocates itself.
Yes. Yep. You got it. Right on.
Right. Yeah. So you guys just remove a section of the skull so the brain could kind of swell out.
Yes.
You've seen brain? Have you seen actual brain?
Yes, I actually have.
Yeah. That's cool. Is it pink and fluffy?
No, it's gross.
There's like veins and stuff. Well,
It's gross.
Yeah. Give me 1 second.
You're like, is it plugged in?
No, I forgot. I don't blur out the people right now, but now I'm going to blur out the people. Oops. It's all right. So anyone that went into our frame will be a part of our frame. And I'll point it more towards you. This should be fun.
It's okay. So
anyone that walks by will be seen very well. But yeah, go on. You've seen brain outside of the body, really.
yeah, but we don't want to talk about that. Well, people.
We do want to talk about it. That's exactly what I want to talk about. Let's see.
But basically, so we'll let the brain swell outwards, and then we'll watch them, and hopefully they don't. Usually with those kind of patients, they are going to be disabled for their life.
Oh, after the craniotomy,
Yes,
no matter what?
There's very rarely there's some sort of deficit that they receive where they still can't use part of their brain, part of their body. So basically, those are strokes. Strokes are, if you have a loved one who has a stroke, it's very important to call 911 and bring them to the hospital because there's so much man can do. So we want to do it when we can, not when the stroke has what we call completed and there's nothing you can do. And then there is other things. So that's one aspect of neurological emergencies. And then we have another thing, which is more congenital. You're born with it, which is a bursting of an aneurysm in your head. So the most common aneurysms are in a structure called the circle of Willis in your head, in your brain. And the circle of Willis is like a circle, and it's like basically like it innervates around your brain. I'm not the most technical person on it, but that's it. That's like the basic definition of it. And what happens is, all your life, you won't know really until you start getting symptoms, is that a blood vessel starts to balloon outwards because the blood vessel gets weakened. And it's usually an artery with what I'm talking about, and it's called a subarachnoid hemorrhage. Subarachnoid is also an anatomical area, so subarachnoid is an area in the brain. and hemorrhage. It's bleeding out. And we also grade it off of what we call a Hunt and Hess score. So it's 4 levels, 1 through 4, 4 being the worst, and usually what we call moribund, usually meaning the patient is very likely not to survive with any type of quality of life. Or you have grade 1, where the person catches it on time and they get an intervention, and they're okay. But it's all really congenital, I believe, and it's basically the artery just weakens, and one day you wake up like if you're an EMS and your loved one says they woke up, they vomited, and then they passed out. You're gonna think
that's like anything with the brain.
You immediately think that's something with issue with the brain, even if they're a heavy drinker, because heavy drinkers also get massive brain bleeds too. So that's a brain issue. And you take them, you get a brain scan, and usually you'll see blood. So in a CAT scan, blood is white in the CAT scan. And basically, with that, they'll put in a external ventricular brain. So with these aneurysms, they bleed into the 3rd and 4th ventricle of the brain. And the brain doesn't like blood touching its tissues. It's very irritating to the brain. And there's also a similar kind of issue called a AVM, but we'll go with that. We'll talk about that later. So a subarachnoid is nicknamed an ASAH, aneurysmal subarachnoid hemorrhage. They'll stick a drain into their head during the the neural IR suite. And they'll start decompressing the brain. Like I said before with the Monroe-Kelly doctrine, there's a certain fixed amount of space in the head. And if that starts, if that very, very special ratio gets unbalanced, then you really suffer huge deficits, and one of them being herniation of the head, herniation of the brainstem. With subarachnoid hemorrhage, it's usually the main arteries of the brain that get affected, if we catch it in time and they're not having issues, they're following commands, they don't have any type of deficits, they're going to stay in the hospital for 23 days. And the reason for that is that with subarachnoid hemorrhages, there's this thing called vasospasm. And vasospasm is bad.
Okay.
And even though we will try to prevent it, most times patients will go into vasospasm. So what is vasospasm?
Right.
Vasospasm is those arteries that got touched by the brain. They spasm because the blood is irritating it.
Oh, wow.
So those vessels constrict.
Okay.
And when those vessels constrict, the tissue that they're innervating with blood can start to stroke.
Okay, right.
So they can have a stroke.
Okay.
So that's one of them. So that's another main issue. And basically with that, it's a medical emergency. So we'll watch them and the significance of their days. So when we give report, I'm like, this is Joe Smith. He's a grade 3 subarachnoid hemorrhage. He's on day 6 vasospasm watch. So usually on day 6, that's when you're going to start seeing issues. And one of the symptoms of vasospasm, and I don't really understand the etiology, is called cerebral salt wasting, meaning the brain, for whatever reason, starts reducing its serum level of sodium by peeing. It looks like diabetes insipidus. They just keep peeing.
Oh, wow.
Yeah, they're dumping liters and liters of fluid. They're just peeing it all out, which also makes those vessels smaller and makes them at risk for choking because their vessels aren't dilated, they're dehydrated. So one of our care bundles for that is that They are always on high fluids. They're always getting bolused, and they're usually on hypertonic solution, which also has another benefit.
Do you know why the brain keeps sending signals to just keep peeing? Is it something with hormones?
I'm not sure. I have to look it up, really, honestly, with the cerebral salt wasting, because it's so weird to me. But every patient that I've had with a subarachnoid hemorrhage, they will start
just
salt
pee
wasting.
like crazy.
Yeah, and it's all of a sudden, you know, like you start getting more and more like, okay, we have to really watch them, you know?
That's crazy.
Because then they can start stroking out because they're
Right.
really
Dehydrated.
vasospasming. We'll also give them a high dose of fluids, like normal saline, like at 125 an hour, and then we'll bolus them a liter just to keep them hydrated, and then we'll also put them on 2% of hypertonic sodium.
Okay.
So what does that mean? Hypertonic. So there is also delayed DCI, delayed cerebral, I think, ischemia, so there is swelling in the brain because there's a bleed and the brain tissue is being irritated. So there is edema, cerebral edema. So 2% or mannitol, those are high dose salty concentrations. Fluid follows salt. So you're pulling the edema in the brain, the edema out of the tissue of the brain into the vessels, and they also start peeing it out.
Oh, right.
So
you want that kind of.
Yeah, you want that.
You're like, it's in your brain, we want it out of
Yeah,
that.
so they'll put them on that,
That's
and
really
that also
cool.
makes them pee a lot. So it's such a balance. So they'll do that, and they'll want to keep the patient's serum sodium very high. So our normal serum sodiums are 135 to 145, but with someone who is on vasospasm watch, they're going to keep it up in like the 145, 150 range to keep that swelling from the brain control. So the other aspect of subarachnoid care, and those patients will hate you, they're on Q1 neuro checks, and they're also going to be on either Q4 or Q2 every 2 hours, every 4 hours, a medication regimen called nimodipine, which is a calcium channel blocker. So it's, from the articles I've read, they weren't really sure why, but this certain kind of calcium channel blocker helps increase the prevention, but does not totally prevent vasospasm of the brain.
Okay.
And then they're also going to be, for 23 days in ICU in the hospital, they're going to be going for these things called TCDs, transcranial Dopplers.
Okay.
So they take a machine and they put it like up against like here, and they see how there's like a little bit of magic that they check the velocity ratings, the readings.
Oh, with the Doppler?
With the Doppler.
That's nuts.
And from what I understand, if the velocity readings are higher, that means that they're in vasospasm.
Okay.
So if they're in too much vasospasm, they're dumping, they're symptomatic, they're going to go back down to the neurological suite, and they're actually going to go through that femoral artery, go all the way up to the brain, and they're actually going to inject calcium channel blockers into the artery to stop that vasospasm and try to prevent stroking.
Holy crap.
Yeah. So with vasospasm, you're at risk for stroke. With the brain bleed, you're at risk for herniation. It's a huge issue.
Wow, that's very cool.
Yeah. So usually what they'll do, and then when you come back, they'll say like, oh, they got 5 milligrams of verapamil injected into the artery, and like because it's blood and blood is so irritating to the brain, there is still going to be vasospasm. But we're trying to reduce the severity of symptoms and hopefully have a better outcome of life for the patient. So it's very dramatic. With the external ventricular drain, with the patient who has those moribund diagnosis, like a grade 4 Hunden-Hess subarachnoid hemorrhage, you're going to see them have elevated intracranial pressure too when they're in vasospasm. So the normal intracranial pressure, again, is dictated by the Monroe-Kelly doctrine, and that is less than 22 ICP, intracranial pressure. And it correlates. The intracranial pressure is a waveform that you can see on the monitor that's being transduced by the catheter that's in the brain from the external ventricular drain.
Can you explain that?
So they put a drain into the brain, into the ventricle of the, did they call you?
No, you're fine.
They put a drain into the ventricle of the brain to help relieve the pressure
Okay.
of the head.
Because it's high intracranial pressure.
And that can cause herniation.
Okay.
And they have a catheter that can transduce the waveform
What's that
of
mean?
the intracranial pressure.
Transduce?
So you know how when we put a patient on a monitor, we'll see their heart rate,
Okay.
and it has that P wave, QRS.
Right.
So there is something very similar to EVDs, where there is a waveform of intracranial pressure that correlates with the heart rate
okay.
and the blood pressure.
I see.
Yes, it's very interesting. And there's a P1, and then a P2, and a P3. I don't remember exactly what they all represent.
Wow.
But one is represented with the heart rate, one is represented with the choroid plexus, and one is represented with the blood pressure, with the VAP.
Okay.
And that also plays a role. So we will monitor their ICP. I think the highest ICP I've ever seen was 42, which is like very dangerous. They're such at risk for herniation. And usually those patients are intubated and already have an airway. And we will give Versed, we will max amount of propofol because we want to sedate them to relax them because their intracranial pressure is going up because they're in pain. Their brain is in so much pain from the blood decomposing in their head.
Okay.
And another aspect of, we also want to record the ICP because it also plays a key role into their blood pressure. So with patients who have subarachnoid hemorrhages, we are going to do what we call liberating the blood pressure. So all your life, you hear a high blood pressure is bad, hypertension is bad. With these patients, we want them to be hypertensive. We want them to be as high as 220. Okay. That's a high number, right? And the reason for that is that we want them to have a high mean arterial pressure because we're going to subtract the number of ICP from the map that we get when we take a blood pressure. So there's the systolic, diastolic, right? No, I'm sorry, the systolic blood pressure and the diastolic blood pressure.
You guys actually do all these calculations?
Yes, we have to. And then there's the map, right?
That just sounds like theoretical.
No,
stuff.
it's actually
legit.
it's actually
practical.
It's actually practice.
Wow.
And then you have the map, right? The map is that number that's in the parentheses. And the map correlates with the ICP. So you get the ICP. The ICP is 10, which is a good number. That means that the brain isn't in any type of crisis. And their map is 110. So you subtract the ICP from the map, and you now have the CPP. The CPP is the cerebral perfusion pressure, how much of the brain is being perfused, which correlates to us going, okay, their perfusion, we want a number between 70 and 90. Sometimes some of our neurointensivists want it higher sometimes, maybe like in the hundreds, and that's okay, because that means that we're also guarding against them having a stroke because their brain is being perfused, and that's so important with vasospasm. So that's subarachnoid. It's very complex. It's so and the reason why I know the most about this, and I'm no expert on it, is because I've had a lot of patients who had subarachnoids, and the patient family members always come up and they always ask these questions. What does this mean? What does that mean? So you start to get good at explaining it.
Wow.
And it really helps them because, when your family member's in the hospital, it's scary.
Uh-huh.
Yeah.
And it serves as like a pacifying behavior for the family member. It's like, hey, whatever she just said,
It sounds like she knows something.
Yeah, right. It sounds like she's in good hands, right? Or he's in good hands.
Yeah, and basically, so that's essentially like the bread and butter of subarachnoid. That's nursing care. Neuroscience and neurosurgeons have like a whole deeper, complex understanding
I'm sure.
Than I do. I just know how to take care of them and and then run to them. I'm like, yeah, their ICP has been like 36 for 5 minutes. So do you want to give them some fentanyl?
Right.
So, and then we have AVM ruptures, which is also a congenital issue where it's basically in the head that you have like all these blood vessels and arteries that are like kind of tortuous.
Okay.
And they just burst.
And by tortuous, you mean like
They're all like tangled.
Right.
So basically, yeah, that's neuroscience nursing.
That's cool though. That's really awesome stuff. Yeah.
And you always have to bring them cats in.
One of the things that I realized about nursing that was like actually a surprise to me was, we're like the maintenance after like procedures, or we're the ones that do the intervention.
Yeah.
After the doctor, like I remember everyone in class was like, we can't prescribe medicine as a nurse. That's bullshit.
Even though we can recommend it to them.
Yeah. That's funny. It's very funny. I think of, I can't wait for the day that software gets so good that any hospital just needs to download a piece of software and then they could just do the procedure off of like a robot.
I think they're actually trying to develop that.
Oh yeah? Do you see anything like that in the hospital? Any fancy technology that's replacing procedures? Like LASIK is really complicated, but yet we got it down to about $5,000 because of a robot, right? So hopefully they do that for brain issues.
I don't remember, honestly, anything recent. But I know that that's what they're trying to do. And they're trying to do more outpatient surgeries when they can.
Okay. But what's an outpatient surgery? You mean
like if they can go like, you know how I got my wisdom teeth removed from an office?
Oh, and then just get that put out.
And then go away, or get my tonsils. So they want to do that because longer stays in the hospital correlates with like a poor patient outcome.
Okay. Yeah, and it's expensive.
And it's super expensive.
Right. I think the best way to make healthcare cheaper is to do just that,
Yeah.
Make it more effective, make it more available.
More safe, more available, more cheaper.
Yeah, exactly.
Yeah. So, yeah.
It's definitely a lot of cool stuff with neuro.
Yeah. I mean, I don't know, I'm going on my second year as a neuroscience nurse. I want to stay in neuroscience, critical care for maybe like 5 years, and then switch over to trauma.
Okay.
That's my goal, and but I want to just like sit into one specialized field and really understand it.
Right. So you're in NICU right now. Now there's a trauma unit?
They're
Like a trauma ICU?
they're kind of melded together with
Right.
the medical ICU.
That's what it seems like.
Yeah.
It seems like you get some trauma, they get some trauma, depending on what type of case. Who do you think's probably on shift? You know,
Yeah.
stuff like that. Yeah. It's like, hey,
Well,
Marlo would like something like this. And he's like, let's send her over there.
But yeah, I can't wait to go into trauma. But I definitely want to specialize in neuro ICU for a bit, and then I'll specialize in trauma. But I think my heart is in trauma. But I
Okay.
find neuroscience very interesting. But it all involves the brain. They like joke around with like neuroscience people. Like I remember like me and my friends used to joke that they'd be like, yeah, they might be like on a heparin drip for a small blood clot in their head and they're pooping out blood clots, but the neuroscience team will be like, but how's their neuro exam? And it's just like, okay, well, their neuro exam's fine, but
Right,
they
but
have a
they're dying.
different-
Yeah. That's funky.
Yeah. So that's it. That's who I am.
I heard that there's a stroke ambulance from Stony Brook, and I know does Northwell? Do you know?
I don't think Northwell has one.
Okay.
Maybe they do.
Yeah, they might. And all it really does, I think it just has like a CAT scan, but they have like real names.
amazing.
They have like PAs and nurses on that ambulance.
Wow.
Yeah, and they're specialized in these strokes. Because you know that within 3 minutes of a stroke, you're losing brain cells like crazy.
Yeah, and you
So
want to protect those brain cells.
I definitely see a lot of room for growth in a stroke ambulance. You know, that like literally. Maybe some of these procedures, these thrombectomies, where they go through the
It's
femoral,
already at bedside.
right? It's just there. It's like chilling, right? Technology
But
gets good enough.
thrombectomies are like a sterile surgical procedure.
Right, it's
so
gonna
if
be
they
tough
can
to do now.
I hope one day that
Robots are pretty sterile.
Yeah. I just hope one day maybe we can just get like a little wand,
Yeah.
wave it, and then
That'd be so cool. Oh, how cool would that be?
Their cloud is gone.
Yeah. Imagine they had something like that. Like for instance, you know that one where they put it on your bladder and it breaks up the stone from like seismic
Yes.
activity?
Oh my God.
Maybe they'll come up with something like that for like
Yeah,
the brain.
but that doesn't like fuck up the brain.
I know, probably not that one. But who knows? Who knows? Maybe they'll have it so targeted seismic waves that could just break up the clot.
Yeah.
That'd be really cool.
I had a patient that I actually received from the mobile stroke unit from Stony Brook, but he got so messed up from the TPA. We all like questioned.
The TPA?
Yeah.
Oh yeah, because
Because it makes you bleed everywhere.
right. It's like now your body cannot clot anymore.
Yeah,
For,
then-
for how long does that last? Like,
Honestly, the guy that I got, he started bleeding. He was bleeding for like weeks.
really?
He had so what happened with him is he got TPA, but then he started getting a GI bleed.
Oh Jesus.
Yeah,
And then what? Right.
and it was very complicated from the GI bleed.
There's so much issues that will just happen. Like you solve this issue, but now you have this issue.
Yeah,
Right?
and that's why it's a high risk medication.
Okay.
That's why
That's
you
why
can't.
you really want to use it in
yeah.
ICU.
That's why you can't.
You want to transport the patient. You're not going to do it on the streets.
Well, yeah,
Some people. But
the
yeah.
main goal with patients who have strokes is to get them to the ER, and the ER has to get them up to us because that's where they need to be.
Okay.
Yep. Like you don't want them sitting in triage for like hours. Like we need them up in the ICU bed. But yeah, I mean, I'm getting my ENLS certification.
Okay, right.
And hope our new neuro suite's going to be opening tomorrow, and we'll see. I'm sure they're going to get much more sicker cases
That's
now
cool.
that they have
So you're going to be on
specialized-
the new unit next
Yeah.
time? So I guess next coffee time you'll tell us about how the new unit is.
It looks like a hotel.
Oh really?
I toured it. I was
Nice.
like, yeah, they're gonna get people that are only gonna go for like,
Maybe
elective surgeries of their brain.
Will they have like new coffee machines and stuff like that? Or?
Oh, I don't know, but I know in our ICU we have a coffee machine and patients get free coffee, and
Yeah.
I get to make myself free coffee.
You're out of your coma? Need some coffee. That's sweet though. That's pretty sweet. I used to love that. Was the coffee any good there?
It was decent. It's decent. It doesn't have sugar, so I'm not a fan.
Oh, really?
I like sugary stuff.
Oh, they don't even have sugar there.
They do, but it's not as good as having nice sweet coffee that's
see.
warm. So yeah, that's it.
Cool. All right, coffee time 2. And then I'll mark it like coffee time 3, coffee time. It's like Mike and Marlo, coffee time 1, coffee time 2.
I wouldn't know what to even talk about for coffee time 3.
I know, right? Well, we could just keep talking. You know, or any experiences, as long as you blank out like any identifiers.
Yeah, as long as I
obviously.
don't, like,
Right.
I'm not
Because
talking
right,
about
experiences are so important to share,
Yeah.
and it's what people like to listen to the most. You know.
I gotta say though, with like, with being in the ICU, I feel like it's such a character builder, because you see, like, you complain about your life, and you start pitying yourself when you have like adversary in your life, and then you go to work and you see how much your patients are going through, and they're going through a lot worse. Like they're suffering, you know, major disabilities for their life, and some of them have like the best attitudes about it, and it really humbles you, where you're just like, all right, you know, me being upset over, you know, my card battery dying is not as bad as someone losing a limb.
It helps you put into frame your daily issues.
Yes.
It's like, okay, relative to this guy's issue of dying from a brain bleed.
Yeah. Or they're not Joe Smo anymore.
Yeah.
You know, they're not you know, Apple's.
He lost his ability to blink and his control of his bladder.
Yeah, and that's you know, that's really devastating when all your life you lived your life normally, and then you get this major complication and you can't use one side of your body anymore. You know, and then all of a sudden you're on antidepressant meds that make you have all these side effects, and you know, now you have nausea, now you gain like tons of weight, you know, etc. So that's what I like nursing, but like when things are going down, you're like sitting there and you're like, I hate my life. And you're like, I'm panicking with you, man. No, but you have to keep calm. But it makes working in the ICU has made me appreciate the time spent with my family more, and like just being in general good health.
Something interesting to bring up is that nursing is almost like the study of what happens when things go wrong in the human body.
Yes.
You know?
And how to take care of that.
Yeah. It's it's kind of like when you see society, like right now we're in like a fragile spot, like everything's going well, no one really questions society, but then when things start going wrong, it's like, holy crap, you know, there's panic all over the place, you don't know if you'll be able to repair any of these damages. Yeah, so it's really complicated stuff.
Nursing care goes hand in hand with medicine. You know, like we need each other, and you know, like we've seen a lot. You know, we've taken care of like very, very sick people, and you know, like with the pandemic, you know, that really brought up to what nursing care means to everyone. Yeah. All right, coffee time 2 over. Yay.